When we're thinking about IUI and IVF in patients with PCOS, there are some particular considerations. For instance, in IUI, we would still be using a medication to induce ovulation. We may decide to target a slightly higher number of follicles. So in somebody who is starting their fertility journey with PCOS, our goal might be ovulation induction, maybe 1 follicle. Maybe by the time we get to IUI, we might be trying to get 2, maybe 3 follicles to improve the odds of pregnancy. That might mean that we're using a higher dose of an oral medication or potentially adding in those injectable gonadotropins.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together. Hello, everyone. Welcome back to another episode of My Fertility Podcast. This is episode part 2 for polycystic ovarian syndrome, or PCOS. To listen to part 1, refer to episode 16. Today, we're going to be talking about treatment of PCOS. There's really lots to talk about because the treatment of PCOS really depends on the goals of the person. Your goal could be to get pregnant. Your goal could be to have regular cycles. Your goal could be to protect the endometrium from the endometrial hyperplasia. Your goal could be to control the hirsutism and the acne. So it's very important to understand the goals of the patient before discussing treatment options.
It's really important to keep in mind that there is no one single treatment for PCOS. And as we said, the treatment or what we're going to talk about really depends on what the particular goals are. That being said, there are some general guidelines and some general things to consider when we're talking about managing PCOS for all patients, regardless of what their specific goals may be. One of the big things we talk about with PCOS is around lifestyle and lifestyle factors, in particular things like weight loss, diet, nutrition, and physical activity. We know that with patients who are overweight or who are obese, that if they lose even 5 to 10% of their body weight, that can actually significantly reduce the severity of their symptoms, including things like menstrual irregularity or the acne or the hair loss or hirsutism. And it's also important to keep in mind that there's no scientific evidence for a specific best way to lose weight when somebody has PCOS. And that's important advice for every single person who's trying to maximize their health. But really, there are some certain guidelines and things to consider when we're talking about diet nutrition, for instance, when we're talking about PCOS. There are some specific, let's call them dietary patterns, that may help manage PCOS symptoms. For instance, because insulin is such an important component, managing blood sugar levels, reducing those big insulin spikes can be helpful for patients with PCOS. And one way to do that is to have a diet that's high in fiber and complex carbohydrates, staying away from things like white bread, white rice, and then focusing more on things like whole grains, quinoa, brown rice, which has a higher fiber content. Patients with PCOS should also think about incorporating more anti-inflammatory type foods. So things with omega-3s, that can be fish. Fish is a really big source of omega-3s, nuts and seeds. Flaxseed is a big one. And because we know that higher levels of insulin and insulin resistance, you can have this sort of ongoing low-grade inflammation. Omega-3s can be helpful. Again, omega-3s can be helpful for everyone, but they might be especially helpful for patients with PCOS. And then, of course, for anyone trying to lose weight or trying to improve their diet, minimizing refined carbohydrates and sugars can help manage weight and insulin levels. That is a really important component for PCOS and for other patients who are trying to maximize their health. That being said, nutrition counseling is tough, and trying to figure out a diet that works for you for the long term is challenging. Sometimes getting help from a dietitian can be especially helpful so that you can find something that works for you that's sustainable and effective.
Another important aspect of managing PCOS naturally is physical activity. Exercise improves insulin sensitivity, which is, again, an issue with women with PCOS, and it can help with weight management as well. It's important to look at a combination of exercises such as aerobic exercises, walking, running, cycling, and resistance training. Resistance training is actually crucial because this is the way that you can increase muscle mass. Increased muscle mass can lower insulin resistance and increase metabolism. The American College of Obstetricians and Gynecology recommends at least 150 minutes of moderate intensity aerobic activity together with resistance training at least 2 days a week, but ideally 3 to 5 days a week.
So if somebody is really focusing on cycle irregularity as that being the number one thing that we're trying to manage or that we're trying to treat, then it's important to distinguish if you're someone who is trying to conceive now or not, because some of these treatment options are contraceptive and can prevent pregnancy. In PCOS with cycle irregularity, that can mean that the cycles are really short, meaning they're coming very frequently, less than 21 days, or really irregular, more than 35 days, let's say between that first day of the period to the next first day of the period. Cycle irregularity can also mean things like having really prolonged periods that are going on for more than 7, 10 days, 2 weeks, 3 weeks even, or ongoing spotting between periods. These are all going to be encompassed around cycle irregularity. If someone is not actively trying to conceive, not trying to get pregnant, then the oral contraceptive pill is often the first line treatment for managing the menstrual cycle and also can help with some symptoms of those elevated androgen levels. The way that I always tell patients is that, PCOS is a hormonal imbalance, and that is the crux of why patients have PCOS symptoms. Sometimes we have to give a bit of hormones to help regulate out the overall hormone levels, and that will help regulate the menstrual cycle so that you can have regular, predictable bleeding that is lighter, reducing those androgen levels to reduce the symptoms associated with that, like the acne and the excess hair growth, and provide endometrial protection. It doesn't just have to be the birth control pill. You can also use a birth control patch or birth control ring. A hormonal IUD can be another option that's really good for endometrial protection. When somebody has a hormonal IUD in, they may have very light cycles or just spotting or even potentially no menstrual period at all. And that can help with some of those symptoms of having really heavy bleeds or really irregular bleeds while still protecting the endometrium. Hormonal IUDs aren't so helpful when it comes to managing symptoms of those elevated androgen levels like hirsutism or acne.
Now, if you're trying to conceive, there are different options for managing the desire to try to conceive in the setting of polycystic ovarian syndrome. One option would be cyclic progesterone. As we talked about in the prior episode, one of the issues with polycystic ovarian syndrome is that there is anovulation or lack of ovulation, which means no progesterone is being produced. One way to manage this is by giving patients progesterone for about 7 days in a month, and this will induce a menstrual cycle. It doesn't prevent ovulation in case somebody's ovulating naturally, and it's also very good for endometrial protection. Now, progesterone in itself, it's not an ovulatory agent, so just giving somebody cyclic progesterone isn't a treatment to induce ovulation and establish a pregnancy. But it is a treatment that one can use to induce withdrawal bleeds in the setting of PCOS without stopping the possibility of natural ovulation. Another option is metformin. Metformin is a prescription medication used to treat type 2 diabetes. It can lower insulin resistance, which, as we discussed, it is an issue with polycystic ovarian syndrome. Studies have shown that women that have polycystic ovarian syndrome, especially if they are obese, when they take metformin, there could be resumption of spontaneous ovulation and natural cycles. So that is certainly something that we can try. It does have some side effects, in particularly GI-related side effects like diarrhea, nausea, bloating, and constipation.
Thinking more about fertility and people who are trying to get pregnant, when somebody is seeing us in the sense of Market Fertility Center as fertility physicians, they may have considered things like cyclic progesterone or metformin with their family doctors. But the first thing that we always talk about, and it's worth talking about again, is lifestyle management and lifestyle changes. Whether it's looking at weight, whether it's looking at exercise and diet, that's still first line treatment for patients with PCOS who are looking for help with trying to conceive. Then we often talk about ovulation induction agents. So this is a group of medications that we use to induce ovulation. Right now, the most popular medication is something called letrozole. It's also called Femara. Letrozole is a medication that's something called an aromatase inhibitor, which means that it blocks the enzyme aromatase that converts androgens to estrogens. Basically, when you have these lower estrogen levels that the body and the brain is seeing, the hypothalamus and the pituitary gland, so the brain, will release more hormones like FSH and LH. That FSH and LH will then travel through the whole body, including to the ovary, and induces the ovary to create ovarian follicles, to grow those follicles, which create higher estrogen levels as a byproduct and thereby promoting ovulation or kickstarting ovulation.
And I'm going to interrupt here. If you don't know what FSH and LH is, go back to episode 2 of this podcast where we talk all about the many actors and actresses of the menstrual cycle.
Letrozole is very highly effective in inducing ovulation in women with PCOS. And there are studies that have shown that letrozole can be more effective than other medications like Clomid, which we're going to talk about, especially in women who are resistant to Clomid. And generally, there have been studies comparing the two, and letrozole has been shown to be a bit better with higher live birth rate and lower rate of multiple pregnancies, meaning twins or triplets. Letrozole, it's typically given in a dose anywhere from 2.5 milligrams, 5 milligrams, or 7.5 milligrams. It's a pill taken on a daily basis for about 5 days, and it's typically started on cycle day 2 or 3. Another big advantage with letrozole is that it does not affect the lining of the uterus or the endometrium in the same way that Clomid used to. When Clomid was more popular 10, 15 years ago, we saw some people would have a thin lining, but letrozole doesn't have that effect because it's a bit more specific of a medication. It is worth noting that it is an off-label use of this medication. If you go and you Google letrozole or Google Femara, you'll find that it's a medication that's also used in patients who've had breast cancer in the past. But there are many medications that are used off-label, and what that simply means is that this medication was not specifically approved for use in fertility by the US FDA or Health Canada. It's still considered safe, and it's still the most commonly used fertility medication right now. It's just the drug company has not made a specific application to Health Canada to use it for this particular thing. And frankly, they probably never will because there are costs associated with that to create the studies that would let them to do these applications. There's lots of examples in medicine in general where we're using off-label medications. And again, it's not that it's not safe or it's not that it's not studied. It's just that it doesn't have that specific application into Health Canada for that.
Another medication used to induce ovulation in PCOS is clomiphene citrate or Clomid. Clomid is a selective estrogen receptor modulator. What this means is that Clomid works by binding to the estrogen receptors in the brain, therefore blocking that negative feedback between the estrogen produced by the ovary and the brain. Because the brain is now not seeing the estrogen, then it creates the effect of making more FSH and LH, which is going to lead to follicular development and eventually ovulation. Studies have shown the ovulation rates are about 60 to 80% in women with PCOS taking Clomid. Some of the side effects include hot flashes, bloating, breast tenderness, nausea, and a small percentage of women may have visual disturbances as well. One issue with the anti-estrogenic effect of Clomid is that it can cause thinning of the endometrial lining and changes in the cervical mucus, which it's not ideal when you're trying to establish a pregnancy. There was a very important study called the Pregnancy in Polycystic Ovarian Syndrome study, which compared letrozole and clomiphene head-to-head in terms of pregnancy rates. And it showed that letrozole had a much higher live birth rate in women with PCOS compared to clomiphene citrate. The likelihood of a live birth is increased by 40 to 60% with letrozole compared to clomiphene. On a similar note, failure to ovulate or resistance, it's lower with letrozole than it is with clomiphene. It was also noted that multiple pregnancy rates appeared to be lower with letrozole than with clomiphene. The most common side effect noted in the study was hot flashes, which can happen with both clomiphene and letrozole, but is less common with letrozole than it is clomiphene. Therefore, where clomiphene used to be in the past the agent of choice, after the study, And after more evidence, letrozole has become the agent of choice for inducing ovulation in polycystic ovarian syndrome.
And as we sort of briefly talked about metformin earlier, I think it's also good to talk about letrozole versus metformin. I think a lot of patients who are coming to see us might already be on metformin, potentially for ovulation induction when they have PCOS. Let's say they're seeing their family doctor. Family doctors for sure have a high level of comfort of prescribing metformin, and there might be an element of insulin resistance. But I tell people metformin's an okay medication for inducing ovulation, but letrozole for sure is better. There have definitely been lots of studies that show letrozole generally induces higher ovulation rates compared to metformin alone, and they have higher pregnancy rates as well compared to metformin alone, especially in women who are clomiphene resistant. And in fact, sometimes we'll actually combine metformin with letrozole, so have a patient on both of these things can be really effective for women who do not respond to letrozole alone. It seems to have this sort of synergistic effect of improved insulin sensitivity, and even higher gonadotropin release can improve ovulation and pregnancy rates. I think that's a really good point, that sometimes it's not just about doing one thing and then trying a second thing. Sometimes we end up layering in these different medications together to get the desired effect of ovulation.
So we've talked about letrozole, we've talked about Clomid, and we've talked about metformin. These are all oral medications that can be used to induce ovulation in polycystic ovarian syndrome. There is another class of medication called gonadotropins. These are injectable medications. They come in the form of FSH or LH, and they can also be used to induce ovulation in women with polycystic ovarian syndrome. Now, they're highly effective in patients that have resistant ovaries, so ovaries that did not respond to oral ovulation induction agents like clomiphene, letrozole, or metformin. Multiple studies have shown that the use of gonadotropin significantly improved ovulation rates compared to placebo or no treatment in women with PCOS who did not respond to prior treatment. Now, there are many risks associated with gonadotropin in PCOS, and one of those risks is the risk of over-response. In other words, while with letrozole and metformin, maybe you're making 1 or 2 follicles, with gonadotropins, you could be making 3, 5, 10 follicles, which of course would put you at very high risk for multiple pregnancies and leading to cycle cancellation, because it wouldn't be safe to tell you to do an IUI or do time intercourse when a person have about 4 or 5 follicles because of the risk of multiple pregnancies. There is also increased risk of ovarian hyperstimulation syndrome, which is something that is very commonly associated with the use of gonadotropin in women with polycystic ovarian syndrome. And there is a significantly higher cost of using gonadotropin for ovulation induction in PCOS compared to using oral agents.
Another way to help with fertility in patients with PCOS and to improve cycle regularity is through a surgical method called ovarian drilling. Now, the name sounds a little scary.
It sounds very scary, yes. I don't want anybody drilling my ovary. Sorry.
I know. I just imagine people, whether you're in your car or you're home right now, just imagining this massive jackhammer going into someone's abdomen. But that is definitely not the case. I agree, though. It is a bad name. But ovarian drilling is a surgical procedure that we can do, that we use a laparoscope, put a camera in through the belly button to have a look at the pelvis and to look at the ovaries. And you create multiple small holes in the ovarian cortex, or the outside of the ovary. And we're talking around 10 holes, but each hole is measuring 1 to 4 millimeters in size. So these tiny little holes. I would call the surgery maybe ovarian dimpling instead. I think that sounds nicer.
That sounds way nicer. You're really good at names.
The goal of the procedure is to disrupt this thickened ovarian capsule and to reduce the number of androgen-producing ovarian cells that we know are in the cortex of the ovary. So if we burn those ovarian cortex androgen cells, we're going to rejig the hormonal balance to hopefully induce ovulation. The goal is to restore that ovulatory function by decreasing those androgen levels. Again, sometimes that's not always the case, but at least maybe we'll make somebody more sensitive to using an oral medication like letrozole or clomiphene that we mentioned earlier. Studies have shown that this procedure can effectively restore ovulation in anywhere from 50 to 90% of women with PCOS who were previously anovulatory, who previously weren't ovulating. And this improvement is actually comparable to other ovulation induction therapies. like the medications clomiphene or letrozole. While the evidence regarding pregnancy rates after ovarian drilling is quite variable, several studies have reported pregnancy rates ranging anywhere from 30 to 70% within the first year post-procedure. The likelihood of pregnancy and conception appears to be influenced by age, of course, BMI, and whether the fallopian tubes are open. I mean, that's a pretty big one. When you look at the specific hormone levels after somebody has had this procedure, you will see that there are significantly reduced circulating levels of those androgen hormones, including testosterone and androstenedione in women with PCOS. This is why we think that ovarian drilling works. Long term, there are very limited studies looking at if you do the surgery now, what's going to happen a few years from now. But it is thought that these beneficial effects of this surgery may persist beyond the immediate post-operative period, with sustained ovulation and menstrual regularity for even up to 5 years after this procedure.
I think it's important to know that this is not a surgical procedure without risk. This is a laparoscopy. That means that you need to go into a hospital, you need to go under full anesthesia. An instrument needs to be inserted into the abdomen, so there is a risk of bowel injury and vessel injury right there. And then when you're doing the ovarian drilling, there is also a theoretical risk of ovarian damage and decreasing ovarian reserve. This is an acceptable treatment option, knowing that there are so many oral medications available, like we talked about already, metformin, clomiphene, letrozole. Then ovarian drilling will fall out of favor because of the risks associated with the procedure. However, there are patients where it would be a good candidate for ovarian drilling. That would be patients where the oral medications have not worked at all and they're not able to do IVF, because that would be another option. If you need to use gonadotropins, like we said before, it might be difficult to use gonadotropin just to induce ovulation and have pregnancy that way, but certainly gonadotropins can safely be used in the setting of IVF.
And I think it's also important to point out that when we are doing the surgery, we do it, I don't know, rarely. I think once every couple of years, I think I've done it. It's kind of arbitrary. And so what I mean by that is that you're making these little holes, these little puncture sites, these little dimples, if you will, but you know the depth that you want to go, a couple of millimeters. You have an idea of the number of them. But there's no equation to sort of say, okay, if I make this number of holes, I'm going to restore ovulation for sure, and that patient's not going to need oral medications. Or this number of holes is going to give somebody 6 ovulatory cycles for the next 5 years. You do it, then you kind of see what happens after. And that's a really tough one in terms of counseling patients about it, where it's like, well, you know, we're going to do the surgery and it's probably going to help with restoring ovulation, but we don't know for sure. You kind of have to do it and then see what happens after.
Yes, for sure. Surgery is not something to be taken lightly. That would be very low on the list of options for polycystic ovarian syndrome when there are so many other options.
There's another supplement out there that can also be used for helping to restore ovulation and that menstrual regularity, and that's inositol. And inositol is something that we've talked about previously. Inositol is actually a carbohydrate, and it's a form of a sugar alcohol that plays a role in cellular processes, including insulin signaling. And so what it does, it improves insulin sensitivity by acting as a secondary messenger in this insulin signal transduction. Basically just means that it makes the cells better at picking up insulin and being more sensitive to insulin, which is, we know, is the opposite of what happens when somebody has PCOS. When you're out and you're purchasing inositol, or if you're looking on the containers, they talk about myo-inositol, and there's also these D-chiroinositol, or DCI and MI. Studies have shown that myo-inositol especially improves insulin sensitivity and reduces serum insulin levels. That's the insulin levels in the blood. This can help lower androgen levels, which can help with symptoms like acne and excess hair growth. There's research that shows that myo-inositol can help restore ovulation and improve fertility rates in women with PCOS. There's a study that showed that women taking myo-inositol had a higher ovulation rate and some improved egg quality in comparison to those who are not taking. Inositol is not something that necessarily needs to be used in isolation. We can use it along with metformin, potentially along with a medication like letrozole. Inositol is something that you can get over the counter as a supplement.
Everything that we talked about so far is with the goal of inducing ovulation in the setting of PCOS. Now, inducing ovulation is only half the equation. Just because we're able to induce ovulation doesn't mean that pregnancy is going to happen. It is not uncommon for women with PCOS to do a letrozole cycle or metformin cycles, and then 3 cycles later, 6 cycles later, we have documented that the medication worked in inducing ovulation, but pregnancy still hasn't happened. There are still other treatment options available for PCOS and fertility, namely IUI and IVF.
When we're thinking about IUI and IVF in patients with PCOS, there are some particular considerations. For instance, in IUI, we would still be using a medication to induce ovulation. We may decide to target a slightly higher number of follicles. So in somebody who is starting their fertility journey with PCOS, our goal might be ovulation induction, maybe 1 follicle. Maybe by the time we get to IUI, we might be trying to get 2, maybe 3 follicles to improve the odds of pregnancy. That might mean that we're using a higher dose of an oral medication or potentially adding in those injectable gonadotropins. Again, more follicles does mean that there's a higher risk of multiples.
And that is something that's very important to consider. IVF is a very good option for women with PCOS and a very safe option as well. There are some nuances to doing IVF in a person with PCOS, particularly the risk of ovarian hyperstimulation syndrome. What this means is that as we give you gonadotropin, because the ovaries have so many follicles present, as we talked about earlier, your estrogen level can go very high and you might produce a high number of follicles. Could be 15, could be 20, could be even higher than that. Now, there are medications that we can use to reduce the risk of ovarian hyperstimulation syndrome and still be able to retrieve all of those eggs in a way that is mature and they're able to fertilize. So IVF can still be a very wonderful and effective and safe treatment option for PCOS. Remember at the very beginning of the episode, we talked to you about the treatment of PCOS has to be tailored to the goals of treatment for the patient. So everything that we had talked about so far in terms of clomiphene, letrozole, metformin, ovarian drilling, myo-inositol, it's when the goal is to restore ovulation, not necessarily cycle regularity, but restore ovulation for a potential pregnancy. Now, if the goal of treatment is to control the abnormal hair growth or the acne, there's other options available. For example, the combined oral contraceptive can reduce acne and the abnormal hair growth associated with PCOS. There's a medication called spironolactone as well that can help with that. Very important to know that you cannot conceive while you're taking this medication. So it's important to use alternative method of contraception because it is unsafe for an early pregnancy to be taking spironolactone. There is also treatments for hair removal like waxing, shaving, electrolysis, and over-the-counter treatment for acne.
Long term, when we're thinking about PCOS, it's associated with an increased risk of other long-term health complications, like we talked about previously, type 2 diabetes, cardiovascular disease, endometrial cancer. And so really regular monitoring and long-term management strategies are also important. It's not just about getting pregnant, not just about fixing the acne or helping with the acne. It's really important that women with PCOS undergo regular health screenings for things like glucose intolerance and looking at their lipid panels, cholesterol panels, and blood pressure. Lifestyle interventions that we started this episode with, like managing weight, exercise, good nutrition, are really, really crucial for the longer term things with PCOS as well. We've spent a lot of time talking about PCOS. We've talked about the symptoms, diagnosis, and the treatment options for PCOS. But I gotta say, I always tell the story when I see a patient with PCOS where they're struggling with this diagnosis, and I can tell that it's a really tough thing for them. I used to have a mentor, and if she's listening to this right now, shout out to her because she's awesome. But I used to have a mentor when I was in training who used to say that if you're going to have a fertility problem, PCOS is the best one to have. She used to get a lot of weird looks. But I see where she was going with this, right? What she means by that is that when somebody has PCOS and there are so many different treatment options and there are so many different ways that we can work with somebody to help induce that ovulation. And it's something that is pretty well studied. And it's one of the few things in the world of fertility where we can give an oral pill to help people, right? Without necessarily needing to move right into IVF. And that's what she was trying to get at. And nobody wants any fertility problem. And they're all bad. Let me be clear here. But with PCOS, at least there are lots of treatment options. And it can just be, for some patients, as simple as trying an oral medication and doing cycle monitoring to help people get pregnant. And again, people with PCOS tend to do really well and tend to have really high pregnancy rates and fertility outcomes.
So I hope that you find this useful. We'll see you next time.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.
Hello, everyone. Welcome back to another episode of My Fertility Podcast. This is episode part 2 for polycystic ovarian syndrome or PCOS. To listen to part 1, refer to episode 16.